Now, hemolysis. Hemolysis. Hemolysis, no matter what the etiology is, has certain things in common. Number one, it's not always, but it's often acute. Let's put it this way. You can have chronic hemolysis, sickle cell, hereditary spherocytosis. However, if it's acute, drop in hematocrits, there's only two ways to get an acute drop in hematocrit. One is blood loss. And if I got a gallon of black stool slurping around the floor and making my diapers black, then I know it's blood loss, or if I'm vomiting blood. Now, the only other way to lose a large volume of red cells is hemolysis. So all things that are hemolysis are not always acute. But if it's acute, it has to be either loss or hemolysis. Let's put it this way. Acute drop in hematocrit, acute hemolysis, acute drop in hematocrit, acute anemia, minus blood loss, generally speaking, equals hemolysis. Now, you might say, hey, dude, how do you know that there's not vomiting, nasal blood, epistaxis? Because it's never a diagnostic question. No one has a occult 1 liter loss of blood out of their nose, vagina, or lungs. Acute anemia minus loss, which is almost always GI loss, equals hemolysis. And you can think of it like that. Now, not all hemolysis is acute, but when there is acute bleeding, or acute blood loss, acute anemia, think of loss and hemolysis. Now, what else do they have in common? They have an MCV that is either normal or slightly raised. Either normal or slightly raised. And the reason is production problems cannot change the MCV acutely. Hematocrit changes over weeks. When you have a red cell that lasts for 120 days, so you cannot have a red cell that lives for 120 days changing size by production problems. MCV is normal or slightly raised because of the high reticulocyte count. Reticulocytes are slightly larger, like baby fat. So that's why it's either normal or slightly raised. Production problems cannot acutely change MCV. You need generally 2 months. Now, everybody with hemolysis gets an elevated reticulocyte count, an elevated LDH, an elevated bilirubin, indirect bilirubin, elevated indirect bilirubin, elevated LDH, elevated reticulocyte count, and most of the time a decreased haptoglobin. Retics, LDH, bilirubin, haptoglobin, most of the time. Now, when the blood cells are destroyed intravascular, in the vasculature, intravascular. Now, there's also extravascular. You know, when I was in medical school, everybody used to say, yes, extravascular. And everybody else seemed to know where extravascular was. So I didn't want to ask. I didn't want to say, where's the extravascular? Because everybody else seems to be doing this. Oh, extravascular. Yes, of course. But extravascular, where is that place? And then one day I found out that extravascular means the spleen. And I said, why didn't you just say the spleen? I know where a spleen is. Why do you say extravascular when you meant liver and spleen? Oh, wow, we can't make it easy and understandable, because if you know everything, then what do you need me for? Gotta keep you ignorant. So intravascular is in the vasculature. Extravascular means in the spleen. Now, intravascular hemolysis is the one that's most often associated with the decreased haptoglobin, because that's the role of haptoglobin. Haptoglobin transports red cell hemoglobin from the vasculature space back to the liver and spleen and reticular endothelial cells, back to have it recycled. The red cell, boom! The hemoglobin is released. Help, help, help! And the haptoglobin takes the freely released hemoglobin and brings it back so that it can be recycled in the bone marrow, and that's why you only need 1 milligram of iron a day, because it's been recycled. Now the haptoglobin gets used up because it's like all the theaters opening up at 10 o'clock every night on Broadway, whatever city you're in that has a Broadway, and that is that all the theaters open up. The buildings let out all their people. All the taxi cabs get used up because there's a limited number of binding proteins for the hemoglobin, and the level goes down. The same way if you go out and try and get a taxi cab at 10 o'clock or 10:30 when all the theaters have just let out, you'll find that all of the binding proteins have been attached to the newly released molecules called people coming out of the theater. So you come out on the street, hey, there's no taxis because all the taxis have been used up. Wait a while and then it will replenish. Hey, the red cells have gotten destroyed. All the haptoglobin is used up in the same way as no taxis on 10:15 at night when the theaters get out. Now, if you don't know what I'm talking about, get a life, and then you'll see what I'm talking about. Stop that tape. Go to the theater right now. Glad to have you back. Intravascular will drop the haptoglobin. The other thing about intravascular is it will make the urine dark. That's the other part about intravascular. It will make the urine dark. And what is it dark with? Not bilirubin. Not bilirubin. Not the bilirubin. Most common wrong answer. Not the bilirubin. The thing that makes the pee-pee dark is free hemoglobin. Now, what do you call it when there's hemoglobin in the urea? Hemoglobin urea. Yes, hemoglobin urea, because hemoglobin freely filters into the kidney at the glomerulus. But bilirubin does not go into urine. Bilirubin does not go into the urine because this is indirect. Indirect bilirubin is waiting to be processed in the liver. And until it's processed in the liver, the indirect bilirubin is attached to the albumin. I can't let go of the albumin. It's not that I don't want to filter. I want to filter into the glomerulus just like all the conjugated bilirubin, but I can't. I'm tightly bound to this albumin and I can't let go. So unless this albumin's spilling into the urine, glomerular nephropathy, I'm not going into that urine. So the indirect bilirubin is not able to go into the urine because it's attached to the much larger carrier protein and can't make it out of the blood vessel into the urine because the carrier protein is too big. The indirect bilirubin is having an intimate relationship with albumin and it doesn't make it into the urine. What makes it into the urine is hemoglobin. That's why you can get renal failure and acute tubular necrosis from things that cause hemoglobinuria, myoglobinuria, pigments, hemoglobin, myoglobin, hemoglobin, myoglobin, hemoglobin, myoglobin in the kidney tubule. Because hemoglobin to the kidney tubule is like an albino being out in the Sahara Desert without sunblock. Ooh. Burns it, fries it, oxidizes it, hurts it. And those cells inside the kidney tubule get sloughed off. The cells in the kidney tubule get sloughed off because they've been oxidized by that hemoglobin and slough off into the urine. That's why the hemoglobin is toxic. Hemoglobin, myoglobin, hemoglobin, myoglobin, hemoglobin, myoglobin in the kidney tubule. Fries it up. Tubule tempura. Fried up tubular cells. Ooh, tasty. Can I have some of that hemoglobin fried tubular cell? Ooh, that's very nice. Ooh. Tubular cell tempura in hemoglobin sauce. So that's what all forms of hemolysis have in common. This is what the intravascular ones have in common. And remember that the dark urine is not bilirubin. It's hemoglobin. Indirect bilirubin does not filter. Now we have many various kinds of hemolysis. Sickle cell is probably the most common, the one that everybody's going to see. However, we also have autoimmune hemolysis, hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, and glucose 6-phosphate deficiency. So we have a number of kinds of acute hemolysis, just making sure I'm going in the right order. Sickle cell, autoimmune hemolysis, hereditary spherocytosis, PNH, G6PD deficiency. Hey, which one of them has a high reticulocyte count? All of them. Which of them has a high LDH? All of them. Which of them has a high indirect bilirubin? All of them. So rather than relearning this over and over again, why not just say they all do this? Now what's different? What's unique? What's special? That way we don't have to keep learning it 5 times over. What is different about the glucose 6-phosphate dehydrogenase deficiency that is different from paroxysmal nocturnal hemoglobinuria? What's different about that from the hereditary spherocytosis? And what is different from hereditary spherocytosis? Don't just say spherocytes, because it happens to be that autoimmune hemolysis gives spherocytes too, because when the antibodies are attaching to the red cell membrane, the antibodies are pulling out pieces of that red cell membrane and taking a bite out of the red cell membrane. So what the antibodies are doing attached to that red cell membrane is they're biting out a pinch of each, and it can turn it into a spherocyte. So not just spherocytosis has spherocytes. What's unique? The antibodies can bite a piece of the membrane, bite a piece of the membrane, bite a piece, and it makes it smaller and rounder and tighter, and it turns it into a spherocyte. So that's something, spherocytes, that can happen in spherocytosis as well as in autoimmune hemolysis. Now, what is different about sickle cell from these? Because that's the most complex. Do we need to see the spherocyte again? Okay, it makes it smaller and rounder. Big content, small membrane. Makes it look small, tight, round spherocyte. Now, sickle cell is going to get addressed separately because sickle cell disease has the most amount of unique questions to it. Because sickle cell disease is one that is having the most unique tests and treatments. So therefore, the sickle cell disease comes out with its own unique presentation. It also comes out with its own unique tests. It has all of these, but more. It has more than all these others combined. We got a 48-year-old guy who comes to the emergency department. He says he's got pain in his chest and his back and his thighs, in his chest and his back and his thighs. We got a 48-year-old guy who's got no temperature, no fever. I should say no fever. We all have a temperature. We don't all have a fever. He's got a normal oxygen saturation, 99% O2 saturation on room air. He's got no fever, a normal saturation, and he is saying, I have pain. Gee, really? Have you ever had gallstones? Bilirubin gallstones? He says no. And you say, people with chronic hemolysis are always making a lot of extra indirect bilirubin, so they have bilirubin gallstones. But he says no. Well, okay. Did you ever have lower extremity ulcers of your skin? And he says no. People with sickle cell infarct their skin, they get ulcers. Nobody really knows why, but you get them. Okay. Have you ever had osteomyelitis? And he says no. And people with sickle cell have bad bone circulation because the oxygen content of the bone is lower, so people infarct their bone, get bone lesions. And they get osteomyelitis. Staph aureus, I'm afraid to say, is number one. Salmonella just is unique to sickle cell. So I know that always comes up, and let's start our disagreements now. Conrad Fisher says that if they ask you what the most common organism is, you should say Staph aureus. It's just that sickle cell doesn't occur in anyone else except the sickler. If you read somewhere where it says Salmonella is the most common, we will have to, as Yogi Berra says, agree differently. So therefore, osteomyelitis occurs, and he says, no, I haven't had osteomyelitis. I haven't had any aseptic necrosis of the femoral head, which happens when people are infarcting their bones and they get aseptic necrosis and dead bone disease. And he says, no, I haven't had any of that either. Oh, Then he says, well, listen, guy, you got no fever, no acidosis, no hypoxia, no infection, dehydration, nothing that goes for infection, dehydration, acidosis, infection, dehydration, hypoxia, acidosis, infection, dehydration, hypoxia, acidosis, which are the things that usually predispose, promote, or lead to sickle cell crises. You don't have any aseptic necrosis of the femoral head, osteomyelitis from infarcting the bone, lower extremity ulcers. You haven't had bilirubin gallstones. You haven't had any of these things. What can I do for you? He says, I want drugs. Oh, what kind of drugs would you like? I would like a little morphine and a lot of codeine. I'd like a little Dilaudid. I would like some Vicodin. I'd like some Percocet and Percodan. I would like a fentanyl patch. I'd like MS-Contin, long-term continuous acting morphine sulfate. On the other hand, I could do with some oxycodone. And you know what I'd like for dessert? A fentanyl lollipop. Tasty. Listen, have you ever done this before? Oh yes, I go to a different emergency room every month and they give me everything I want, and so should you. Now, oh wise, gracious, compassionate healer of the future, you decide to let him sit there and suffer because you don't trust him. What's the best initial test to diagnose whether someone has sickle cell disease right now? What's the best initial test? The most accurate test is a hemoglobin electrophoresis. But let me see. Gee, I seem to have lost the ability to do an instant stat bedside hemoglobin electrophoresis. So that is the most accurate. What's the best initial? What can you do now? Hey, they all have high reticulocytes. They all have a high LDH. They all have a high indirect bilirubin. They all could have a low haptoglobin. But they don't all have a smear that shows sickled cells, which he has. And you rush forward to apologize as you start the fluids, the oxygen. And he goes, what about the pain meds? And you go, all right. Pain medications. The only thing is, can this smear tell you the difference between sickle cell trait and sickle cell disease? Can this smear tell you the difference between trait and disease? The answer is yes. The answer is that it can tell you the difference. In other words, what do you see in a smear with sickle cell disease? Gee, with sickle cell disease, on the smear, you should see sickled cells. That's it. On sickle cell disease, you should see sickle cells. That's it. And what do you see on a trait on a smear? On a trait and a smear, you see exactly nothing. Normal smear with sickle cell trait. Normal CBC with sickle cell trait. You see normal smear, normal CBC. You see a normal smear and a normal CBC is what you see with sickle cell trait. That is the difference. And the other thing is, the only significant manifestation of sickle cell trait is the renal manifestation. Hematuria. In my urine, I see hematuria, which is red cells going into my urine. Hematuria isostenuria. Isostenuria. Iso, where we get the word the same from. Same. Stenos, the Greek word for strength. Isostenos uria. The same strength urine as the blood, because you can't concentrate it, you can't dilute it, it's the same strength. Isostenos as the urine in the blood together. The only clinical manifestation of trait is the renal manifestation, is the only significant clinical manifestation. Now, who should get the antibiotics? Not everybody. Well, clearly, if you have an infection, yes, you should get antibiotics if you have an infection. Clearly, if you get an infection, yes. But who else besides having a definite infection? I mean, if you have pneumonia, sure, you should get antibiotics. The answer is just by having a fever. Just by having a fever, you should get antibiotics. Why? Because people with sickle cell don't have a spleen. And if you wait for the cultures to come back, they're going to be dead. So what you're learning right now, if you forget it, you fail step 2 and they die. Because antibiotics with fever and a sickle cell lower mortality. If you wait for the results of culture, that's bad. You become a mortician's delight. But if you give the antibiotics before the cultures come back, you will have stopped the infection before they develop their first clinical symptom, which is usually, I'm feeling mighty dead today. They have no spleen. They're immunocompromised. They're going to get wiped out. Give them the antibiotics just for a fever or a very, very high white count. Fever or a very high white count. The antibiotics. It's like neutropenia. If someone had a neutrophil count, absolute neutrophil count less than 500, and they developed a fever, you would give antibiotics even without waiting for the results of culture. Because just by giving the antibiotics, you are going to lower mortality. Fever and neutropenia equals antibiotics. Now, this is the routine management. Most people will get better with this. 90% of sickle cell patients with acute sickle cell crisis are going to get better with this. What about those few number of people who develop suddenly, on the 3rd hospital day, suddenly the hematocrit dropped from 32 to 22 in a 2-day period? That's too much for this to be dilutional. It's too much for this to be dilutional. What causes large volume hematocrit drops in people who have sickle cell disease? And the answer is that it is parvovirus B19 is the etiology. Parvovirus B19 dropping the hematocrit. Now, parvovirus B19. Gee, what does B18 do? I'm not going to tell you. What about B20? I'm withholding that information. The president disavows all knowledge of parvovirus B18. The answer is there is no parvovirus B18 and there's no 20. What about A19? What about A1 through 20? There is no parvovirus A1 through 20. There's only one, and it's parvovirus B19. Sounds like a good name for a punk group. I'm parvovirus B19. And I'm here to say, I'm going to make you drop your hematocrit. You're going to die today. You better diagnose me with a PCR or you're going to drop dead right where you are. So people who have parvovirus B19, there is no B1 through 18 and there is no A. It's just the one single organism. So PCR for DNA, PCR for parvovirus DNA, and if they don't put in the answer, the PCR for DNA, the IgM antibody against the organism. If both are in the question and it says, what is the most accurate test? You'll say PCR. If PCR is not there, the IgM antibody against the organism. Parvovirus B19 causes a sudden drop in hematocrit in patients with hemoglobinopathy. The nurturing cell inside the bone marrow in patients with hemoglobinopathy are particularly vulnerable to infection by parvovirus B19. Parvovirus B19 works entirely on the newly growing cell and freezes the bone marrow at the level of the giant pronormoblast. Although you can easily find multiple giant pronormoblasts in the bone marrow upon biopsy, this test is far more painful, inconvenient, slower, and uncomfortable than simply testing for parvovirus B19 DNA by the PCR. Therefore, the parvovirus B19 should be suspected when a patient with hemoglobinopathy, such as sickle cell disease or thalassemia, develops a sudden drop in hematocrit in a short period of time. This is because of the freezing of the reticulocytes, and that 20 to 30% of the bloodstream, which was reticulocytes, has been eliminated. The intravenous treatment for parvovirus B19 is intravenous immunoglobulins to block the damage to the bone marrow. The answer is intravenous immunoglobulins. The last thing for sickle cell disease is, what if this guy had developed the worst form of sickle cell disease, which is the guy comes in saying, hey, I happen to have acute chest pain and I also am having signs of visual disturbance because I'm infarcting my retina. Visual disturbance as the sickle cells go in the back of the eye going in the back of my eye. What if I start developing CNS disturbance and signs of a stroke as the sickle cells are going into my brain going ooh, damn, that hurts. What if they're developing acute chest syndrome, visual disturbances, signs of a stroke or malignant hypertension of the penis? Priapism, stroke, visual disturbance, acute chest syndrome. What would you do if the person develops the most life-threatening forms of sickle cell crisis? Interestingly, that is less of a hard question than this parvovirus question because people end up knowing to do exchange transfusion. Let's get rid of that bad sickle cell blood and put in some normal blood. Let's get rid of that bad sickle cell blood and put in some normal blood. Essentially, it turns them into a heterozygote. How do I get them to go from the experience of being SS, homozygous for sickle hemoglobin, and turn them into a heterozygote? I get rid of 25, 30, 40% of sickle hemoglobin and replace it with normal hemoglobin, and you stop sickling. Because the normal red cells will prevent the sickling of the others because of the oxygen carrying capacity and diluting it out. Now, when do we answer hydroxyurea? Don't you think you ought to start with the case? Well, no. Because it is easier to put these together in terms of when do you answer the particular drugs and tests, because you could sit around and make 50 cases of sickle cell disease, but you still have a limited number of answers. Now, sickle cell disease is relatively complex to these other forms of hemolysis. Compared to sickle cell, these others are a walk in the park. Coombs test, give steroids. If it recurs, do a splenectomy. Hereditary spherocytosis, osmotic fragility, and splenectomy. G6PD deficiency, get a G6PD level. Don't get yourself exposed to oxidizing stress. If this has 25 data points, these have 5 each. Hydroxyurea is to prevent, to prophylax, to stop the likelihood of the next sickle cell attack. If you go to the hospital 5 times a year for acute chest syndrome, now maybe you'll just go twice a year. If you go to the hospital 3 times a year with acute chest syndrome, now maybe you'll go once a year or never with your acute sickle cell crisis. It decreases the frequency of sickle cell crises by increasing the content of fetal hemoglobin, which dilutes out that evil, nasty sickle cell hemoglobin. That's why it works. Everybody who's got sickle cell disease should get folate because they're chronically hemolyzing. And the chronic hemolysis means that they're very vulnerable to developing acute folic acid deficiency. And everybody who has sickle cell disease should get pneumococcal vaccination because it is quote unquote functional splenectomy. Meaning the spleen is still there, but by the time you're an adult, it's the size of a golf ball because it's been infarcted away until it's your spleen's not working. Pneumococcal vaccine to augment splenic function. What do we do first as a diagnostic test for acute patients? A smear. Smear will tell the difference between trait and disease. The most accurate test is an electrophoresis. You should give oxygen fluids and pain meds to everybody who comes in with sickle crisis. Antibiotics is if you, 1, have an infection, 2, have a fever. Don't wait for the results of culture if you have a fever. Take the culture and give the antibiotics while waiting for the result of culture if you have that fever. For a person who suddenly dropped their hematocrits, think parvovirus B19 with the hemoglobinopathy and test for it and give intravenous immunoglobulins. Acute chest syndrome, strokes, visual disturbance, priapism, do exchange transfusion to decrease the concentration of the sickle hemoglobin. And finally, to prevent the next crisis, hydroxyurea and pneumococcus vaccination to prevent the pneumococcal sepsis. Now, all of these others are relatively much easier because the only significant test for autoimmune disease is the Coombs test. Coombs test is going to tell us that the person has got antibodies attached to their red cell membrane because when one red cell is near the other red cell, is near the other red cell, is near the other red cell, and these red cells are all covered with these nasty, yucky anti-red cell antibodies, what happens in the Coombs test is that the reagent is able to tack on to all these antibodies, and the reagent is able to say, well, let's grab a piece of that one, and a piece of this one, and a piece of this one, and a piece of this one, and is able to form agglutination by tossing in an IgM, the Coombs reagent, which says I grab that red cell, that red cell, that red cell, pull them together, and I have aggregation of the red cells. That's a positive Coombs test that is relatively unique for autoimmune hemolysis. Now, why am I going to do a Coombs test and not an osmotic fragility? Well, you might do both, but the autoimmune test is suggested by the history of 2 things. 1, a history of other autoimmune problems such as lupus, CLL, lymphoma, other autoimmune problems, rheumatoid arthritis, that make antibodies, Evans syndrome, autoimmune hemolysis, and rheumatoid arthritis, lupus, CLL, lymphoma. It happens to be that lymphomas are a lymphocyte disorder, and those lymphocytes are making abnormal antibodies. So those abnormal antibodies are agglutinating the red cell, causing hemolysis. Drugs such as penicillin, quinidine, alpha-methyl-dopa, and these all cause you to have Coombs-positive hemolytic anemias because they provoke an autoimmune antibody response. Treat the autoimmune hemolysis with steroids. Yes, stop the steroids, most should get better. Oh, you stop the steroids and yours recurs. That sucks. But what do? You put them on steroids again, and it got better, and you stop the steroids and it recurs. That sucks. So you stop the steroids and it recurs. So what are you going to do when people keep recurring like this? You're going to do a splenectomy when people continue to recur and recur and recur. You do a splenectomy, because the red cells are destroyed in the spleen. So even though the antibody might be attached to them, if I get rid of the site of their destruction, then they cannot be destroyed. They may get covered with nasty antibodies, but they're not going to become destroyed. I just had a new idea. Occasionally use intravenous immunoglobulins also to block the production of those antibodies. What's going to suggest osmotic fragility testing and hereditary spherocytosis? What will be different? One is that the hereditary spherocytosis has a big spleen. That's one thing that's different. The other thing is hereditary spherocytosis has recurrent episodes. It is a chronic, lifelong disease and is either recurrent and sometimes recurrent. So therefore, patients who have repeated episodes of hemolysis and a big spleen course, you need time to get that big spleen. That doesn't happen overnight. I hemolyzed today. My spleen is getting mad. You won't like my spleen when it's mad. That needs time. Now, normal red cells, a normal red cell is a biconcave disc. This red cell can swell and can shrink, and can swell and can shrink, and can swell and can shrink. That's pretty flexible. The red cell, when you put it in a hypotonic solution and it swells up a little bit, it doesn't break, it's got room. It can swell, shrink, it's okay. And that's what's the difference. Because you see, the spherocyte, he's a short, dumpy, fat guy. And the thing is, that spherocyte, unlike the biconcave disc, which is rather like a frisbee, the spherocyte, you know, that poor spherocyte, he can't adapt so well. The poor spherocyte, you know, if the spherocyte, when he swells up with the hypoosmotic fluid, he, pop! The same way, if you have really tight clothes and you gain 15 pounds, pop! Is hereditary spherocytosis microcytic? The cells look small. Hereditary spherocytosis shows small cells that are not microcytic. They're normocytic with a normal MCV. The cells that are normally a biconcave disc, when they get scrunched down into a spherocyte, because they lose their cytoskeleton, they go into what Aristotle and the Greeks thought was the most perfect shape in the universe, the sphere. Now the sphere, even though this piece of paper is the same volume, if I take this volume of paper and shrink it down into a sphere, the sphere looks smaller, but the volume is not smaller. The shape looks smaller than a flattened plane. So therefore, the MCV is normal in hereditary spherocytosis. It's just that it looks smaller. Now, what's wrong with a spherocyte? Well, it carries oxygen. Oh, hey, it carries oxygen. It, carries carbon dioxide. It buffers the body with the hemoglobin buffering acids. It goes to work in the morning, pays its taxes. What's wrong with a spherocyte? It does its job. It's a good citizen of the bone marrow, does its work, goes to the bloodstream, does what it's supposed to be doing. It just doesn't look like you and me. Instead of being sort of biconcave and flexible, it's just a short, little, dumpy guy, a little short, fat guy that's not very flexible, but it does its job. You see, the problem with the spherocyte is not the spherocyte. The problem with the spherocyte is the spleen. You see, a normal red cell is able to move through the spleen with a high degree of flexibility. Hey, listen, the spleen, hey, that's kind of thin, that doorway in the spleen. That doorway in the spleen is kind of thin, 2 microns across. Well, the red cell is about 5 microns across. Well, it's okay. A normal red cell just bends and moves around, bends and moves, and is flexible as it moves through the doorway in the spleen and just moves around it. However, the spherocyte, poor little spherocyte, he's a short, dumpy guy, can't be very flexible. So he goes to the spleen, he's trying to get through the spleen, goes, oh, he Oh, I can't get through the spleen. Oh, my big fat red cell. I can't get through. Oh, the spleen. Let me do it. Oh, pop! And the spherocyte ruptures in the spleen because it can't fit through the little 2-micron doorways. The problem with the spherocyte is not the spherocyte. The problem with the spherocyte is it can't bend around the spleen where it's trying to do the limbo through the spleen. I'm trying to bend the spleen and go to boom! Hemolysis. Lysis, which is a $5 word for destruction. We can't be understandable, then anybody could do this. Destruction of red cells because it gets squished in the spleen like a jelly donut. So the solution is not to blame the victim. If you weren't so short, fat, and dumpy, you wouldn't be getting destroyed by that spleen. Not blaming the victim. It wouldn't have happened to you if you hadn't looked like that. You blame the aggressor. Splenectomy. Splenecto you? No, splenectomy. If you get rid of the spleen, the red cell is not persecuted anymore. It doesn't get squished around, and the spherocyte goes on its merry way, going through the bloodstream, never hurting anybody, carrying oxygen, carrying carbon dioxide, buffering acid with its hemoglobin, and life is good. Now, paroxysmal nocturnal hemoglobinuria is the hardest one because paroxysmal nocturnal hemoglobinuria doesn't fit enormously well. Well, the name helps you. It's hemoglobin in my urine. Hemoglobinuria. And it's not all the time. It's, it's kind of paroxysmal. It's not all the time. It's kind of intermittent. Every once in a while, paroxysmal. Now, here's where we get a little screwed up. When does it occur? Not at night. The hemolysis occurs at night, but the hemoglobin in your urine occurs in the morning, unless you have a prostate problem and you're urinating at 4 o'clock in the morning. It happens to be that when you have a decreased respiratory rate, you get an elevation in your PCO2. When you get an elevation in your PCO2, you have a slight decrease in pH as you develop a slight respiratory acidosis. Now that's not special, that's all of us. We all have a slight respiratory acidosis at night when we breathe because we all kind of hypoventilate, that's called relaxing. Well, that doesn't bother you and me because our cells are genetically normal. Now it happens to be that the red cells in paroxysmal nocturnal hemoglobinuria, that the red cells in paroxysmal nocturnal hemoglobinuria happen to be susceptible to that low pH. The part of the body's blood component that destroys things, bacteria, cells, attack, kill, demolition, is called complement. Now, complement is on all of our cells. Complement. And complement destroys things. And that's good if you got crap in your bloodstream. That's good if you got bad things. It's good if you got a junky car from 1983 and you're trying to get rid of your Toyota Corolla from 1987 to get yourself a new car. You want to junk out your car. Reprocess the thing. Now, the problem is, though, is that the defect in paroxysmal nocturnal hemoglobinuria, by the way, this whole disease is another one of those 90th percentile things. If you're looking for an average grade, you can get by without having to know this entire section. Paroxysmal nocturnal hemoglobinuria is the hardest one. It doesn't fit together so well. So everybody's getting complement on their red cells. However, the complement gets removed. There is a complement removing factor that gets rid of that complement before it destroys your red cells. And that complement removing factor is the precise genetic defect in PNH. PNH is loved by hematologists because it is a very complex genetic disorder that is associated with myelogenous leukemia, aplastic anemia. It's positive for all sorts of genetic defects in the bone marrow because it is a clonal stem cell defect. And what the defect is that the complement that goes near your cells and mine at 3 o'clock in the morning when we're hypoventilating, for them, there is additional activity. And whereas you have a factor to remove that complement before it destroys the cells, the factor that accelerates the decay, the removal of that complement is deficient. And the cells are genetically programmed to be increasingly susceptible to lysis by complement. And that is the defect. You don't hemolyze at night because your complement gets removed by decay accelerating factor. They lyse at night because they are deficient in decay accelerating factor and because the cells are genetically programmed to be more susceptible. And decay accelerating factor is also called CD55 and CD59. And that is the test for paroxysmal nocturnal hemoglobinuria. Looking for the levels of CD55 and CD59 to look at whether or not the person's red cells are susceptible to lysis by complement. That is the diagnostic test. CD55 and CD59 levels. So that's what you look for. There are some older tests, sugar water and a Ham's test. Now you can see why this is such a difficult disease. Because sugar water test, Ham's test, decay accelerating factor, CD55 and 59 are unique to this disorder alone. They're not necessary for any other disorder. There's almost no overlap. And therefore, that's why it's hard for this to learn, because it doesn't fit anywhere else. It's unique here. The other thing that's difficult is that the most common cause of death in paroxysmal nocturnal hemoglobinuria is large vessel thrombosis. Well, why do they get large vessel thrombosis? I don't know. I was on my way to Stockholm picking up my Nobel Prize to figure that out, and I got here instead. I don't know why the thrombosis does it. Why do steroids help the disease? Why do we treat it with steroids? Why do steroids make it better? I don't know. It's a clonal stem cell disorder with a genetic defect. It's associated with aplastic anemia. It's associated with acute myelogenous leukemia. It's susceptibility of lysis by complement at night. You get a decrease in the decay accelerating factor, also known as CD55 and 59, an older screening test with a sugar water test and the Ham's test to make the determination. Now, glucose 6-phosphate dehydrogenase deficiency. How are you going to recognize the test? Why is it that we should get a level of G6PD? You never got one before. Well, what is it that should make you look for the specialized stain known as a Heinz body stain? Heinz body stains? So the Heinz body stain, look at this. Once again, I'm more autistic than I am artistic. You'll forgive my ridiculous drawings here. Why is it that that red cell, you should go looking for the Heinz body? Heinz bodies are not visible on a normal stain. Now, a Heinz body, if you went into your bathroom, your basement, or your garage, a Heinz body, when you see oxidized iron in your bathroom, your basement, your garage, you call that in your bathroom, your basement, your garage, oxidized iron, you call it rust. You call it rust. But the way I figure it, people don't go to medical school for 4 years and get $150,000 in student loans, which is the average U.S. medical school indebtedness, to say rusty red cells. Oh, no, no, no. I could have said rusty red cells for free. People go to medical school to say, I get precipitated oxidized hemoglobin, which is basically made of iron, and it precipitates into these particles called Heinz bodies. Now, the spleen is in charge of keeping the cells clean. So when the spleen sees this red cell, the spleen looks at the red cell and goes, Oh my God, what's that on your shirt? You're a mess. Look at that Heinz body. Clip, clip. You're disgusting. Who dresses you? Clip, 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 and cleans up the red cell, sort of like Queer Eye for the straight cell. Cleans up that red cell and clips off all of that oxidized, precipitated hemoglobin and takes a bite out of that hemoglobin. And when it looks like it's had a bite taken out of the hemoglobin, because the spleen goes, oh, look at that. It's a bite cell because a piece has just been taken out by the spleen. Oh my God, he cares about our education so much, he's willing to eat paper. Oh, yes, it is true. Give me some paper, the whole New York Times. Bite cells, removing those precipitated, oxidized hemoglobin particles. Ooh, tasty. Do we have any salt for this? And that's what you test for the G6PD deficiency. Now, you can't measure a level of G6PD at the beginning because the level of glucose 6-phosphate dehydrogenase is going to be normal at the beginning. In other words, the most deficient cells are going to be destroyed. Glucose 6-phosphate dehydrogenase protects your red cells from oxidizing stress. It's sunblock for your red cells. Oxidizing stress comes by, and the G6PD helps make glutathione reductase, which keeps your red cell membrane in good shape. So what happens when you have an oxidizing stress is that the most deficient cells get destroyed. The normal cells are left behind. So therefore, acutely, the level of G6PD will be normal. Acutely, the level of glucose 6-phosphate dehydrogenase, acutely, the level will be normal. And that's why you have to wait. You have to wait to get the level. You have to, first of all, suspect the disease. Why else would you get it? Number two, you have to wait to get the level. Now, you could tell today the Heinz bodies, but you have to suspect the disease to think to get this specialized stain. So what will be in there to suspect the glucose 6-phosphate dehydrogenase? Well, we got a Greek man, and he's going to a Greek restaurant, and he's having primaquine as an appetizer and fava beans as a main course, and dapsone for dessert. But what's the most common oxidant stress that causes hemolysis? The answer is infection. What's the most common oxidant stress? Infection. That's the most common oxidant stress, is infection. All of those other things, how many people with dapsone have you ever written a prescription for out there? 1% of you? 3% of you? How many of you out there have written a primaquine prescription? 1/2 of 1%? But how many people have infections? That's everybody. Everybody's had an infection. Mama, mama, I am ill. Send for the doctor to give me the pill. Doctor, doctor, shall I die? Yes, my child, but so shall I. Everybody has this. So therefore, infection is the most common oxidant stress. On the first day, we see Heinz bodies and bite cells. You wait 2 months, you get a level. And the treatment for too much stress in your life, what's the treatment for too much stress in your life? Avoid it. Avoid stress. Doc, it hurts when I have primaquine as an appetizer, fava beans as a main course. Doc, it hurts when I eat in the Greek restaurants. Eat Italian. Eat Chinese. Don't do that. Doc, it hurts when I do that. Don't do that. Doc, it hurts when I go out in the sun and I get oxidized. Don't go out in the sun. That's what hurts. Don't get infected. Avoid oxidant stress. Hemolysis fits together because hemolysis You could have acute hemolysis and production problems and not acute. They all give elevated reticulocytes. They all give an elevated LDH. They all give an elevated indirect bilirubin. Most of them have a low haptoglobin, although that's more with intravascular because haptoglobin transports the hemoglobin from the intravascular space so it can be reprocessed in the reticuloendothelial system. What's unique about each one? Look for a history of autoimmune disease or medications to suspect that it's autoimmune hemolysis and get a Coombs test, treat with steroids. Recur, do a splenectomy. You can't destroy red cells in the spleen if you ain't got no spleen. Hereditary spherocytosis. It's hereditary, lifelong, chronic problem, recurrent, happens every once in a while. Need time to get that big spleen. But spherocytes are okay for you. They do their job. It's just the spleen that's the problem. Get rid of the spleen. PNH, hemoglobinuria, first thing in the morning after they hemolyze at night. But the most common cause of death is thrombosis. Get the level of decay accelerating factor because without decay accelerating factor, the complement destroys the red cell. The treatment is steroids. Why? You figure it out. Time for your Nobel Prize. Okay, G6PD. What's the most common oxidant stress? Infection and sudden hemolysis. I excluded the Coombs positive. I exclude. I get a Heinz body smear, and 2 months later I get the G6PD level. And then avoid stress. Are we feeling good about our accomplishments? Have we learned a lot today? I think we have. Do we feel good for a second? Satyam Shivam Sundaram. Ah, yes, the beauty of unlimited knowledge. Satyam Shivam Sundaram. I'll see you later.